I'm now welcome representatives from the Royal Australian College of General Practitioners.
Good morning.
Good morning, Dr. Burgess and Dr. Jones. For the Hansard record, could you please introduce yourselves and state the capacity in which you appear today?
My name is Dr. Frank Jones. I'm a regional ex-procedural general practitioner from West Australia, and I'm president of the Royal Australian College of General Practitioners.
Dr. Zena Burgess, Chief Executive, RACGP.
Well, thank you very much for joining us this morning, and I invite you to make a brief opening statement and we'll continue with questions. Thank you.
Thank you, Senators, for asking us to contribute to this discussion. And thank you again on behalf of my college for the opportunity to appear before the committee to outline our views on the proposed changes to Medicare. My colleague Dr. Bastian Seidel, you met, I think, in your inquiry when you were in Tasmania, informed the committee about the role of the college when he appeared before you last November. So I will proceed with sharing our perspective regarding the current situation. It's quite clear to state the obvious yet again that a strong primary care section general practice has better overall health outcomes. A regular place for medical care is associated with a fourfold reduction in hospitalisation. Increased continuity of care leads to higher patient satisfaction and almost halves emergency presentations. And when an admission does occur, the length of the stay is actually halved. So general practitioners are clinical experts in providing personalised, high-quality care. And general practice is a medical speciality in its own right and the only speciality with continuity of care at its core. Australian general practice patient services have been unfairly targeted by the government to find savings within the health budget. GPs and practices are now faced with an ethical dilemma of providing ongoing quality care balanced against practice business imperatives. And please remember that most general practices in Australia operate as small businesses. The government's changes in December led to an unprecedented protest from GPs. Thousands of GPs contacted the RACGP with concerns regarding the changes and requested advice on how to implement them. Nearly 47,000 patients, GPs and other medical specialists signed our petition to the Health Minister. Others wrote to their MPs and many displayed posters in their waiting rooms informing their patients of the impending changes. We don't often mount campaigns, we're an academic college, but this situation warranted an immediate response. Needless to say, the college, the RACGP and its members do not support the changes. We've provided a submission that provides more detail on our issues with the model and the process used by the government to arrive at their budget measures. And I'd be happy to take questions on that submission. But first, I would like to address the area for real reform and real areas for savings that do not threaten the sustainability of primary healthcare sector or target the most cost-effective part of the health system. There's been absolutely no debate about the cost of specialist services or hospital-based care. Further health savings could easily be achieved through improved chronic disease management, amendments to the prescribing authority hotline, reducing hospital admissions through better investment in primary care, and addressing duplication and inefficiencies in the current system. Quality can be promoted by reconfiguring the GP MBS attendance items to encourage in-depth consultations about diagnosis, therapeutics and prevention, the three areas that GPs are expert at. Voluntary patient registration as part of an implementation of the medical home would transform the way GPs practice and result in better health outcomes for all Australians. We are operating in a very complex health environment. Life expectancy is increasing and the population is ageing. Chronic disease are becoming more prevalent. New technologies are increasing the effectiveness of care, but obviously are increasing costs. Short-sighted changes will not respond to these challenges constructively. Our recommendations to this committee is that the government needs to take the time needed to undertake comprehensive consultation with the profession through the GP College, our colleagues and our patients. Our college represents 29,000 GPs, and we have recommended to government to place a 6-month moratorium on the proposed changes and establish a GP health reform expert group with representatives from GPs, patients and the governments. While I have had brief discussions with the Minister since she took charge, the changes to time-based consultation went off the table. I understand the consultation will end in a couple of weeks, and this is simply not enough time to analyse and identify the serious implications of these changes and will likely result in more budget measures that damage the most effective part of Australia's health system. I have appreciated the opportunity to talk to you, and I'm happy to take any questions. Thank you.
Dr. Burgess, do you want to add any comments at this point? Okay, Dr. Jones, there are a number of very important issues that you raised there, but can I take you to the final comment that you just made? We've heard this morning from the AMA, and it's been on the record on multiple occasions around the country, that consultation has been the thing that has been missing, that has led to the most egregious decision-making that's got everything to do with dollars and nothing to do with health policy. In your closing comments there, you just said that you expect the consultation to go for only a matter of a couple more weeks prior to the government firming up once again another position, having already declared that they continue to remain committed to a price signal. Is that correct? And could you expand on that?
Sure. We've had very brief contact with the Minister purely because of timing issues. We are meeting with her next week. Briefly, we met her last week at United General Practice Australia, and she was very much in the listening mode, and that was good to hear. But the indications were that there was a time limit on the consultation process. I can give you no more information than that.
So there's a time limit on the consultation process with the new minister, but we don't know what the time limit is. But you also said in your opening evidence there that you thought a protracted period, a moratorium of 6 months, is that correct?
We've asked for 6 months so we can all sit down and see what the implications of all the proposals actually are. Because
what we've seen so far is policy made in a vacuum without consultation, and this brief period to make more policy from a government that's got a pretty bad track record, let's face it, should be of some concern to you and your members.
Certainly is, and we, as I say, we think that what we need to do is actually be able to advise government on the implications of policy changes. Their policies are seemingly have been made on the run. No consultation, like my colleague Professor Auler. I also received a phone call about half an hour before the announcements were made. There was no consultation with our college or our members whatsoever.
So they're into pretty short time limits, this government, aren't they? No consultation prior to their budget announcements, half an hour before they gave the version 2 in December, and now, again, time limits on their consultation with the experts in the field.
We believe so. We believe we have some positive solutions that can help government, and we are absolutely willing to talk.
Thank you very much for putting on that on the record. Could I just go to the opening comments that you made about the better health that's achievable? You talked about a 4-fold reduction, halving of emergency and higher satisfaction rates. Could you take me to those two, particularly the 4-fold reduction and the halving of emergency accesses, if we maintain a proper primary health care system without a price signal?
Certainly, there is very good evidence from within Australia and overseas that you've got to pick winners. The high cost end of the system is hospitals. The high cost is within the emergency departments. We know that if you pick the winners, reduce emergency presentations, reduce admission, reduce time in hospital, then you can save money. And that's actually been well documented. It's evidence-based, we know that. The question earlier on about government, do they actually hear what we're saying about the efficiencies of primary care? I think they maybe hear, but they actually don't listen because this message is so strong worldwide. The literature is so strong worldwide that if you have a strong primary care system, it's going to save money downstream. Absolutely no question.
But the government have ignored that to date?
It's seemingly, yes.
And would you say you're concerned that they still might not hear it, considering we've heard that they continue to be committed to a price signal?
Minister Lee, in our brief discussion last week, did acknowledge that countries with strong primary care did save money down this track, so I'm not sure what she's taken it on board and what she's going to do, but she certainly heard that message loud and clear.
But she remains committed to a price signal?
As far as I'm aware.
Thank you. Senator McLucas.
Thank you, Chair. Thank you very much for appearing before the committee. I also want to talk about the consultation process. Did the Minister indicate why there would be why there was a 2-week limit on the consultation going forward?
2 weeks? Sorry, I didn't...
So you said that the consultation would end in a couple of weeks.
Well, that's our impression that there would be a time limit on the consultation.
And did the Minister indicate or anyone indicate why that there would be an end to this consultation?
As I said, we've suggested at least a 6-month moratorium so we can actually sit down and discuss this.
Yes, yeah. And a similar question to one that I posed to Professor Auler. Can you give the committee an understanding of the parameters of the consultation? I mean, as the Minister saying, certain things are on the table, but certain things are definitely off the table. You seem to be telling us that the Minister has said very clearly that a price signal needs to be conveyed. That to me is a co-payment or a tax. So that issue is still on the table, which is... I'm just trying to work out what's in and what's out at the moment in terms of the consultation.
So at United General Practice Australia last week, she said that the same words, that Medicare was not sustainable and that the way that they felt that they could do it was with a price signal. Now that needs to be debated and discussed. The implications I've just tried to outline to you, as Professor Howlett has, it will have huge implications for general practice. GPs will be faced with the ethical dilemma of whether they take a cut in their fees, especially after July 1, the indexation. By the way, the indexation for general practice has been frozen for the last 18 months as is, and now we've got another 3 years ahead. This will put enormous pressure on general practices to provide quality care, because it's about quality care. It's not about the numbers coming through, it's about the quality that we provide for our patients. And we know that if you invest in general practice and prevention particularly, we will actually save money and people's outcomes are better, their health lifestyle is better. We know this. So prevention is often forgotten in this discussion. When I see a patient, I do 3 things. I make a diagnosis, I decide on therapeutics, that may be medication or it may be a referral elsewhere, but I also, embedded in my consultation is prevention. Every single patient I see, every presentation has prevention as a part of it.
So coming back to the parameters of the consultation, the Minister is saying that she is of the view that Medicare is unsustainable. That flies in the face of the evidence that we've heard from yourselves and from the AMA, frankly from I think almost every witness that we've spoken with. How do we make it plain to this government, or are they just not listening?
It comes down to your ethical and your philosophical point of view. I mean, certain countries like Australia, which are relatively well off, I mean, really reflects the fact that we have to have compassion and look after the more disadvantaged patients, people in our societies, no question about that. We also know that if you invest in health, I mean, the social determinants of health are really, really important. And you have a healthier population, you have a healthier workforce, and so it flows on. It's an economic no-brainer.
I agree. Thank you.
Senator Natali.
Thank you very much for your submission. I want to go to maybe a couple of things that were announced, and I'll go to the changes to level A and B, the short consult change. And I'll be honest, possibly to my detriment, but when the change was first announced, I didn't have my reaction wasn't immediately, this is a terrible proposal. It was that we want to encourage quality in general practice, and we need to think carefully about ways of doing that, and at least we're opening up a debate, albeit I think the position I came to was that while the debate was being framed in terms of quality, it was really about cost saving, but at least we've opened up the space to talk about quality. Can you see any merit in a proposal that actually does change the way we incentivise quality? That is, that if, for example, we made changes to short consults, but we reinvested that in perhaps rewarding longer consults or other parts of general practice to reward quality, that there might have been some merit to that proposal?
I think that like yourself, many colleagues didn't realise the repercussions of when the first announcement came out. But on the next day, very much there were repercussions.
Yeah, I found out. I learned very quickly from my general practice colleagues that they weren't enamoured with the proposal.
I think that the evidence that time-based consultations improve quality is relatively poor. It's not good, but there is some evidence. We certainly, in our modelling to government, this is one of the discussions we wish to have with them, is to remodel the ABC system, and we have some ideas, and we've actually done some financial modelling as well.
Good.
But tagged on to that, very importantly, is improving the quality of care. And we have a proposal whereby not just the items of service would be reframed, if you like, and encouraging longer consultations and disincentivizing superficial, if you like, consultations. But tagged on to that, very importantly, are payments for practitioners to provide quality care, for practices to be able to enable practitioners to do that, and also, thirdly, reflecting the complexity of the local demography. So we have modelling along those lines. So I think that we do have some potential solutions to A, improve the health of the population, which is by far the most important thing, but B, to help this government out of this dilemma that's in.
Look, the temptation for me is to focus on how ridiculous some of these proposals are, but I'd like to explore perhaps a more constructive line of questioning. And when you talk about the remodelling to reward quality, I mean, we're talking about because we do have practice incentive payments, for example, that attempt to do that, and we've got some item numbers around care planning and so on that are an attempt to move away from just fee-for-service to look at rewarding quality in general practice. Are you talking about an expansion of practice incentive payments? Are you talking about changing the way we do our care plans? And what do you want to perhaps elaborate a little bit more on?
Yeah, look, I can certainly provide detail if the Senator are interested down the track. But basically, certainly the practice incentive program needs to be looked at very carefully. There's certainly some efficiencies and changes that could be made there. We would see the PIP thing continue within our new model, but again, reflecting the actual payments to practices, not just the practitioner, because systems need to be in place. General practice is complex. We have to have appropriate recall systems. We have to have nurse practitioners. We have to have our nurses involved in all this. So it's not just straightforward A, B, C, D medicine. We have embraced teamwork in general practice. And we do believe that the general practitioner is central to that, obviously. One of the things that disincentivises doctors from employing nurses is, for example, the nurse payment. It's very difficult to employ nurses with a change in some of the government's things. In recent times, the Practice Nurse Incentive Programme, for example, that's gone. So there are lots of ideas that we have, which we would love to sit down with the government and give them some solutions.
Let me ask you about a submission we received from the Hunter General Practice Association, and they focus on unnecessary spending on pharmaceuticals, investigations and so on, what some people will call medical waste. Do you have a view on whether there is scope to achieve savings in those areas?
I do indeed.
And what sort of framework would enable us to achieve that?
And I think there's a whole scope of efficiencies there if we're talking money. That, for example, if I refer a patient to the emergency department, and I've actually worked up the patient already with various blood tests, they're usually repeated.
Yes.
I mean, that is one simple example.
Yes.
I mean, general practice can also do things so much cheaper. There's 4 or 5-fold difference. For example, if you take a skin biopsy in general practice, it's about $62. In hospital, it's about $290. It's the same procedure. So there are huge opportunities for us to look at the whole system.
We keep hearing about that, and I mean, there are countless examples of where we can get those efficiencies, but we're not doing anything about them just yet.
Well,
and I know we can have a conversation about it, and I know that in other settings there have been initiatives set up to try and do that. But I mean, how do we go from talking about the problem to actually starting to put some of this into practice?
Well, I guess it's a little bit like when I teach my registrars to have a conversation with patients, not just a consultation. So I think maybe now we need to have a consultation with government so actually there's an outcome and not just a conversation. I mean, there are multiple examples that we as a college can provide to government with our cost efficiencies. Again, I say reducing disincentivized general practice is really not the answer to Australia's healthcare problems.
Let me ask you the same question I asked of the AMA President. We could have a new Prime Minister next week. If you had one thing to say to an incoming Prime Minister about healthcare, what would it be?
Countries with a strong primary healthcare system have better health outcomes.
They would argue they're strengthening our primary health system at the moment.
Well, unfortunately, by the looks of the dollars and cents, they are not, for the multiple examples we've just given you.
Thank you.
So the core message is don't touch Medicare. It is sustainable, leave it alone. At the very least. Don't break what's not broke.
Absolutely.
Yeah. Senator Cameron.
Yeah, thanks. Welcome, Dr. Jones. I think you've been a bit diplomatic this morning in some of your responses where you say the government seemingly have ignored the importance of primary care. All of the submissions we have is there's no seemingly about it. They have ignored it. Have you got a different view?
Look, I think...
Are you being diplomatic?
Yeah, as I say, we are an academic college at heart, but anything that impacts on the quality of care that I can provide for my patients, I believe that the College of GPs now has to be involved. And look, there's no question that the proposed changes will cut general practice and the services and the quality. And really that's, from my point of view, as a GP, who's been a GP in my town for 30 years, the quality I'll be able to provide for my patients with these rebate cuts, we will have to have a serious look at our numbers in my practice, how we actually charge patients. The day of the announcement, the change in the AB, when I received the phone call from the Minister, we were having a practice meeting that day about how much we were going to have to charge our patients to continue.
Okay.
That's how close it was. That's how close. 3 hours.
Okay. Now, we haven't spoke about another issue. The whole system is very complex, and it's not just GPs. It's a hospital system. It's the university system that supplies the doctors into the system. What are the implications of these cuts to income for GPs, coupled with an increase in costs to be educated, to become a doctor? Has there been a discussion about that?
This discussion is not about income. However, I can tell you that general practitioners are the lowest speciality paid in Australia. With these proposed cuts again, threatening the viability of practices, why would a young doctor choose to be a general practitioner? It's going to make it very unattractive. You might as well go be a salary doctor in emergency department. You know what your income is. Whereas who's going to want to come into general practice with all this uncertainty? So it will definitely have an impact. And we certainly have feedback from younger doctors about...
I was going to ask you, do you mind me interrupting? Have you got any data on what this is doing for young doctors going into training at the moment?
I take that on notice, but certainly we have verbal responses from young GPs. Well, why would I bother? But we can certainly take that on notice, Senator.
Sorry. Yeah.
Senator Cameron.
Yes. Dr. Jones, you said when you see a patient, you do a diagnosis. That's your first thing. I think then you do therapeutics, and then prevention sort of underpins.
Yeah,
is that correct?
absolutely.
If you look at this in the context of the political task to deal with Medicare, would you agree that the government's diagnosis is wrong, and that the therapeutics they're using are the wrong therapeutics?
It's too poetic.
And that prevention is not being done, surely?
I think generically I would say that's probably correct.
Yeah. So they're just not being professional about this?
I don't think I should comment on that.
Why not?
Well, I think that their job is to govern the country. They've been elected by the people. I mean, that's where their primata is.
Okay. The Newcastle GPs in their submissions, they're given very, detailed and very good practical submissions. Not that all the submissions have not been practical, but these are the guys and women at the front line. They say that the proposal is ill-considered, that it's not been modelled. That's the proposals for no indexation in the $5 co-payment. They say they will make Medicare unsustainable. And in the long run will increase government costs, create barriers to care, create workforce shortages, put patients at risk, and reduce infrastructure in the primary healthcare system. Do you get any difference on any of that analysis?
I would agree with all of that.
You'd agree with that. If you agree with that, what's the implications of Medicare being unsustainable?
The implications are you will have worse health outcomes. People will present to their doctors late, potentially more unwell, potentially requiring more investigation, potentially needing more hospital referral, more emergency department presentations. The on-costs are huge. It costs $400 to see a patient in casualty for a semi-emergency. Mm-hmm. It costs $37 to see a general practitioner who is used to dealing with undifferentiated disease and using less and less tests.
Yep. Senator Edwards, one of my colleagues, a Liberal politician from South Australia, says basically if people are sick, they'll find the $5. It's a cup of coffee, you know? But it is more complex than that, and it's not just $5, is it?
It depends on the maturity of our society, whether we believe or not we have universal access to health care or not. We should have absolute equity to everybody, for sure. As a college of GPs, we have never been opposed to the fact that GPs can charge what they feel is fit. That's their own professional prerogative. But certainly we have to protect our disadvantaged. We are altruistic. I mean, that's what we do. That's why we're doctors. And we care for people. Mm-hmm.
Mm-hmm. And what would be the implications in rural and regional Australia?
Oh, I think I'm a regional GP.
Okay.
Very, 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 very much. I mean, I work in a very low socioeconomic area. We have a lot of, for example, opioid abuse, methadone.
Sorry, can I just ask you where you're
Mandurah, West Australia, which is about an hour and a half south of Perth. And we have a low socioeconomic, social class 4 or 5. We have a large methadone prescribing population. There's no way in the world those guys have got money to buy their drugs, but if we don't look after them properly to keep them away from drugs, we start charging them, there's no way in the world that we're going to reduce the opiate abuse. So we bill them. And that would be a really tough call for us in our practice.
So this is an interesting point you make. Drug abuse creates other social complications such as crime.
Of course.
So this could actually increase the incidence of crime amongst addicted Australians because they can't, just not getting the proper treatment.
That is quite possible. I mean, we know there are social implications of health. And this is it runs. If you don't get the things right at the start, the whole thing roller coasters. And that's a very simple example. There are multiple others.
Mm-hmm. I've done a lot of negotiations over my career as a union official. But when you sit down at negotiations and there's polemics, you're poles apart, you're not going to come to an agreement fairly quickly. It seems to me that the organised labour in the medical area are poles apart from the government on this issue. All of the submissions say this is bad policy, it's got huge implications in a whole range of areas. If there's a time limit on the process, how do you think we're going to achieve a proper outcome?
Look, I think all we can do as a medical profession is present the facts as we know them, that they are evidence-based, and it really is up to government at the end of the day what they do with that. They're the elected government. We have all the submissions you've heard. We think this is bad policy. It's not good for the health of Australia. It's going to have ongoing costs. Now, how much clearer do we have to be?
Mm-hmm. Has either the previous minister, Dutton, or Minister Lee, have they given you any evidence of the unsustainability of Medicare?
No. Well, we've read about it, but personally, one-to-one, no.
So they just make assertions, do they?
It's only what I've read in the press releases that they've made about Medicare. In one-to-one conversations, that hasn't been talked about.
And you agree with the AMA submissions that actual per capita, the cost, the actual expenditure has gone down as.
Oh, well, there's certainly good data on that. We've got good data on that as well. If you actually look at the graph, it's very simple. GP payments are there and hospital payments are up there. It's a very simple graph, and I'm sure you've seen that.
Yeah. And, I know that some of the GPs have said that you should look at the hospital system for savings. We also need to be a bit careful about that as well, that we don't create just this push into the hospital system to defund aspects of the hospital system, don't we? It's not a simple issue. It has to be evidence-based, doesn't it?
Healthcare is complex. Every Western world is struggling with the fiscal responsibilities of its ageing population and its chronic disease. When I was a younger GP, it was relatively straightforward. My patients are incredibly complicated now. My cohort of patients have grown older with me. Most of my patients are over 60, 65. They've got at least 5 to 7 medical diagnoses. They're usually on about 5 to 10 different medications. And it really is a different ball game these days. So general practitioners basically are now the expert general doctors of the 21st century. And we know that if you invest in that, it will actually save money into the hospital system. Look, it's a complex discussion. I mean, the states fund their public hospitals. The federals fund Medicare. So, I mean, that's a political dialogue that really needs to take place about that system, because there's such a lot of duplication there. Now, again, that's not my brief today to discuss that with you.
I must say, as a consumer or a patient, whatever, there's all these different things
we call them patients. Actually.
Patients, yeah. As a patient, you go in and you think about medical issues. You don't think... do you think the population really understand that these are small businesses and they've got all the pressures of a small business?
I don't think...
do they see it really medical?
I don't think they understand some do, the actual business implications. Now, we know intuitively, patients know that GPs do a great job, and intuitive GPs do too. The problem with general practice is, opposed to certain other specialities, measuring outcomes is actually quite difficult. So if you're a cardiologist, you know that if you put X number of stents in, you're going to get X number of good results. My patients have got 7 interrelated medical conditions. You mentioned research earlier on. Research in Australia, all the funds primarily go into hospital. Less than 3% of research in Australia, medical research, goes into general practice. And we see 85 to 90% of the population annually. Now, if you're going to talk about research, let's talk about money that goes in general practice. But again, that's not our brief today.
Yeah, well, I just want to come back on this issue of the perceptions and the understanding and the practicalities of dealing with this issue. We've got to try and deal with the issue. Have you seen any evidence that the government or the minister or the minister's staff understand this complexity between providing care and keeping a sustainable business? Has that fundamental issue been engaged effectively with either of the two ministers?
I have not had that conversation with Minister Lay. We had a brief conversation with Minister Dutton in Iran. I mean, he understood the fact that, health is important. He understood that putting some money into...
Well, that's really good for a health minister to understand that health's important.
But he also did understand that primary care is efficient, but he also said that he wanted a price signal.
Yeah. So it's simply this ideology that you've got to treat healthcare as a pure market-based issue.
And that is the impression that I was left with, yes.
So if they do that, then they do fail to understand the health, social and economic implications of what they're doing, don't they?
Well, one would think so.
Yeah. Okay, thanks.
Thanks, Senator Cameron. Dr Jones, Dr Burgess, you'd be aware of the Medical Journal of Australia article by Lourenco, Kenny, Haas and Hall, that's most recent summary of concerns regarding impacts of changes to Medicare bulk billing. And the headline is, "Caution is needed when considering changes to GP fees and Medicare rebates because many of the possible pathways by which patients access the services could be affected." We've heard a little bit of that from you this morning. I just want to close with 2 questions. Firstly, the process by which the government was about to bring in the changes to level A and B was by regulation, which was to get around the Senate. that should only be done in the most extraordinary circumstances, and it should be done after consultation. We've established this morning there was no consultation, so it belies the arrogance of the government in their processes towards the profession and also towards the House of and particularly the Senate.
And patients.
And patients at the core of it. So given the track record that we have of this government in terms of a very unusual way of manifesting their understanding of consultation, concerns that you raised about only 2 weeks further consultation, and I use that in inverted commas now,
Yep.
Could you just put on the record what it will mean, what it will look like on the ground if the proposed changes that we've seen so far from the government go ahead? What will it look like in your practice, and how will it affect your capacity to run an effective business? Because this is a government that says it's the friend of small business, but frankly, every conversation I've had with doctors who run those small businesses and the practice managers is that they've never ever experienced a tsunami of change as was foreshadowed prior to this last backflip by the government. So 2 angles there, the business angle and the patient impact.
I think it will be gradual. I think if it goes ahead on July 1st, I think most practices will actually sit down and refashion their business model. They'll actually see what impact it's going to make on their practice. I think over a period of time, people who will continue to accept the rebate, I'd rather use that term than bulk bill, they will find that their income will go down over 2 or 3 years by between 7 and 10%. That's our modelling approximately. So that's going to be an individual practice and practitioner decision whether they do that.
So some practices you think will just hold out and continue to look after people?
They will monitor very carefully. Well, they'll have to monitor because they've got to pay their staff and their mortgages, and like every other business, they have to do that. They will monitor it very carefully. I suspect that most practices will do their sums and there will be a patient contribution.
So that will change the way Australians essentially interact with their doctors.
Yep.
That you'll have to have money in your pocket if you're sick because you'll need that to access your doctor. That's your prediction if the government continues?
It may not happen straight away, but over a period of months after July 1, practices, if they're doing their monthly financials, will soon find out what's actually happening from their business model, and I think they will have to change.
So this is a government intent on destroying businesses and health at the same time?
It certainly doesn't bode well for the future general practice of Australia if this position is maintained.
Thank you very much, Dr. Jones. And as I indicated to Professor Owler, given the uncertainty about the status of the government at the moment and the tenuous nature of the conversations we might hope are happening, but consultations that seem to be occurring, this committee would be very much happy to take submissions from you about the things that you're advancing so that we keep some of this conversation in the public place rather than behind the closed doors.
Thank you very much for your time.
Thank you.